Good evening, everyone. My name is Larissa Sweeney, and I would like to welcome you to the American Head and Neck Society webinar, Recon Around the World. This evening, we will be visiting with different surgeons from South America. We have a couple of housekeeping items. We request that you please use the Q&A option at the bottom of the screen to input any questions you may have for the panelists. And then if you notice to the right of that, there's a CC caption option. You can click on the arrow and turn your captions on to allow translations to be captured for you below the speakers. And with that, I'm going to turn this panel over to our esteemed moderator, Brett Miles from Northwood Hospital. And take it away, Brett. Thank you.
Great, thanks. Well, welcome everybody to the webinar. This is pretty exciting. We're going to have some South American perspectives on head and neck reconstruction. And I'm really happy to be part of this. We also have Alex Keshner here from Medical University of South Carolina on as a panelist. And so she'll be giving some input. And certainly if you have any questions, please put them into the Q&A function at the bottom of Zoom. We have three panelists, and we're fortunate to have two plastic surgeons on the panel and a maxillofacial surgeon. And I'd like to start out with Professor Raul Sastre Cifuentes, who's a professor of plastic surgery at the National University in Colombia. And he's going to give us some perspectives on facial nerve reanimation and reconstruction. And he's got a wide experience. I've actually seen him present on this many years ago when I was in Colombia. So Raul, thank you for taking the time out to present to us, and please take it away, and we look forward to your presentation.
Hi, thank you very much for your invitation. I'm going to present in Spanish. Voy a hablar sobre la reconstrucción de la parálisis radial en estados tardíos. Obviamente los mejores resultados se obtienen cuando la reconstrucción se hace de forma inmediata. Los objetivos son, primero que todo, la protección ocular, luego la simetría en reposo, en tercer lugar, recuperar el movimiento, pero ojalá que este movimiento sea espontáneo y sincrónico. El panorama depende de que exista un cabo nervioso proximal viable, de la evolución de la enfermedad y de la edad del paciente. Esta tabla elaborada por Zucker nos muestra que hay técnicas estáticas y técnicas dinámicas. Las estáticas, suspensiones, por ejemplo, con fascia lata, cantoplastias y pexias de las cejas. Las dinámicas son de tipo nervioso o de tipo muscular. De tipo nervioso tenemos las neurografias y los injertos de nervio o las transferencias nerviosas o neurotizaciones. Y las musculares tenemos las transferencias musculares o los autotrasplantes musculares por técnica microquirúrgica. Cuando no contamos con un cabo proximal y estamos ante una reconstrucción tardía, debemos entonces utilizar nervios del lado contralateral, el más utilizado, el nervio facial, o de nervios ipsilaterales, los más utilizados, el nervio hipogloso y el nervio masseterino. La transferencia del nervio facial crossface tiene las ventajas de dar una contracción espontánea, una contracción sincrónica, pero requiere entre 2 y 3 puentes de nervio sural de unas longitudes largas de 15 a 20 centímetros, lo cual requiere un tiempo de 6 a 8 meses para una segunda intervención y se indica idealmente en jóvenes o en adultos con lesiones de menos de 6 meses de evolución. Aquí vemos un ejemplo en un niño donde estamos estimulando las ramas que van a ser donantes. Aquí se está poniendo el injerto de nervio sural y finalmente, luego de pasarlo por un túnel subcutáneo, haciendo la anastomosis al lado paralizado. Cuando la enervación es de más de 6 meses, debemos entonces detener el reloj de la enervación por medio de un procedimiento de nodriza o babysitter transfiriendo el 40% del nervio hipogloso al nervio facial. De esta manera se detiene el reloj de la denervación y luego en un segundo tiempo, 8 meses, 10 meses después, se hará la segunda anastomosis. Vemos aquí el caso de un niño que llevaba un año de denervación. Este es el aspecto. Hicimos al año los injertos cruzados del nervio facial. Vemos aquí la anastomosis babysitter con el 40% del hipogloso ayudado con un injerto de nervio sural para mantener viables la placa neuromuscular de los músculos faciales. Al séptimo mes, cuando el signo de Tinel había progresado, hicimos la reconexión del nervio donante a través del crossface al nervio receptor. Fundamentalmente centrados en orbicularis oculi y en las ramas cigomáticas para permitir al paciente la protección del globo ocular y la sonrisa simétrica. Vemos el estado preoperatorio y el estado posoperatorio 3 años después. Aquí está el pre, el posoperatorio 3 años después, el pre, el post 3 años después, donde podemos ver el estado inicial prequirúrgico. Vemos que el paciente ya tiene una sonrisa voluntaria, activa, es simétrica y tiene un parpadeo sincrónico, que es una de las principales ventajas de hacer la transferencia nerviosa facial. Cuando tenemos pacientes con parálisis facial y edad avanzada, el riesgo de ectropión es altísimo. El tiempo es una urgencia, por lo tanto, debemos utilizar transferencias nerviosas ipsilaterales que de forma más rápida van a lograr reinervar los músculos. Pero si se hace una transferencia ipsilateral con el hipogloso o con el nervio masseterino, se produce una sinquinesis, que es bastante desagradable e incapacitante para el paciente. Recomendamos entonces una transferencia dual, en la cual la porción del orbicularis oculi la podemos reinervar con el nervio masseterino, que está muy cercano, a 2 centímetros, y la porción inferior puede ser, si tenemos tiempo, con el nervio facial contralateral o con el nervio hipogloso, dependiendo de la evolución, y de esta manera vamos a poder tener una sonrisa al paciente. La transferencia del masseterino nos da una protección ocular temprana y la transferencia del nervio facial contralateral nos da una sonrisa sincrónica y espontánea. El nervio masseterino es un nervio motor muy cerca, no requiere injerto, provee una pronta reinervación, una mínima morbilidad, pero requiere un reentrenamiento. Aquí vemos en el video la forma como estamos estimulando para asegurarnos de que estamos en nervio motor. Y vemos un primer ejemplo entonces cuando la denervación superó el año. El caso anterior llevaba un año. Aquí la denervación está entre 12 y 18 meses. El nervio masseterino se anastomosa a la rama del orbicularis oculi y un injerto cruzado a la rama cigomático y bucal para proveer una sonrisa simétrica. Aquí vemos la conexión que la hicimos en este caso a través de una incisión en el surco melolabial para poder estar más cerca del objetivo muscular. Aquí vemos las ramas receptoras del nervio facial, del lado paralizado, el nervio masseterino y la anastomosis hecha de forma primaria y un injerto cruzado del nervio facial para las ramas cigomáticas y bucales. Ese es el paciente pre y post. Aquí lo vemos, pre y post ya en expresión, y aquí lo vemos en el video. El nervio masseterino produce una contracción muy fuerte, ya que tiene un gran número de axones. Cuando la parálisis y la denervación es de más de 18 meses y se acerca a los 2 años, las transferencias deben ser ipsilaterales, porque no hay tiempo para que el injerto cruzado alcance a llegar de un lado al otro. Aquí tenemos la neurotización con el masseterino a las ramas del orbicularis oculi y la transferencia o neurotización del nervio hipogloso a las ramas inferiores a través de un injerto de nervio sural corto. Aquí está el injerto sural y vemos esta paciente que llevaba 19 meses lesionada. Entonces ya es una lesión de 19 meses. Vemos el pre y el post, una simetría en reposo, que es un primer objetivo. Y vemos aquí, mientras se incentiva el nervio hipogloso con una colombina para ver el equilibrio que se está logrando con la transferencia dual. Aquí vemos el pre y vemos el video, donde ya protege el globo ocular, pero vemos que con el nervio hipogloso le da dificultad para poder tener una sonrisa espontánea. Tampoco hay un parpadeo sincrónico, es asincrónico el parpadeo y no hay espontaneidad en la sonrisa. Si se toma todo el nervio hipogloso, se produce una atrofia, una hemiatrofia lingual. Por eso se recomienda únicamente tomar el 40 o el 50% del nervio. Cuando van más de 2 años de enervación, se ha perdido ya la placa neuromuscular y se requiere de la transferencia de un músculo sano. En este caso, el más utilizado es el músculo gracilis y el nervio facial contralateral o el nervio masseterino. Aquí estamos tomando la disección del gracilis, la disección del nervio masseterino, el músculo trasplantado sobre la piel, haciendo una representación ilustrativa, la anastomosis nerviosa del masseterino al nervio ramal obturador y la anastomosis a los vasos faciales. Este paciente lleva una denervación de más de 2 años. Vemos el tiempo de crossface, vemos la toma del músculo gracilis, vemos aquí el pre, vemos el post, 14 meses después de la operación, hemos restituido la simetría, el pre y post, y vemos una sonrisa simétrica, sincrónica, y esa es voluntaria, porque se utilizó el injerto cruzado facial. Tiene esa gran ventaja. En el síndrome de Möbius tenemos la parálisis del séptimo par y del sexto par. El paciente no puede ver bien sus globos oculares ni tiene expresión facial. Esta paciente va entonces a ser operada con un doble colgajo, doble trasplante muscular de grácilis, primero para el lado derecho y luego para el lado izquierdo en un segundo tiempo. Aquí vemos al tercer mes la paciente. Aquí la vemos ya en movimiento, tercero, y ya con tus músculos funcionando. Bien. Existe la alternativa de una suspensión dinámica de la mejilla sin anastomosis vascular y sin anastomosis nerviosa por medio de la técnica originalmente escrita por McCaulin y luego modificada por Lambert. Vemos aquí cómo se desinserta el músculo temporal de la fosa temporal, se lleva hacia adelante, se hace coronidectomía y de esta manera se puede alcanzar sin necesidad de un injerto de fascia lata, que es la alternativa, para lograr una suspensión dinámica de la comisura. Este paciente con una neurofibromatosis tipo 1, luego de la resección de los neurofibromas, intentamos la reconstrucción con un injerto de nervio sural, pero ustedes ven claramente en la foto que era un injerto enfermo. Estaba lleno de neurofibromas y por lo tanto la reconstrucción primaria fracasó. Al no tener disponibles nervios, pasamos entonces a hacer la reconstrucción con el colgado, con la técnica de la B. Aquí está el abordaje coronal, el deslizamiento del músculo temporal, la osteotomía del arco cigomático, la osteotomía de la coronoides, para poderla movilizar hacia la comisura, hacia el modiolo. Aquí está la fijación al modiolo, la coronoides, y este es su primer resultado del paciente. Sin embargo, vemos que hay asimetría de la hendidura palpebral, hay una retracción del labio. Hicimos después una cantoplastia derecha para mejorar la simetría en las hendiduras palpebrales y luego un lipoinjerto en el labio superior para mejorar esa retracción que tenía el labio, para tener este resultado. Vemos así antes del proceso reconstructivo y después de una transferencia ortodrómica del músculo temporal técnica de la vena. Cuando estamos ante pacientes de edad avanzada y que no tenemos ese objetivo largo de hacer una transferencia muscular dinámica, podemos hacer las suspensiones estáticas. En este caso, vemos el esquema de la paciente con un injerto de fascia lata y vemos la técnica como estamos fijando el injerto de fascia lata al ala nasal hasta el modiolo para poder hacer una tracción y remedar el surco melolabial. Este es un paciente anciano con imposibilidad para cirugía nerviosa. Hicimos el injerto de fascia lata para hacer una suspensión estática. Vemos aquí el transoperatorio, la tracción, el sentido de la tracción. Y vemos este resultado inicial con una férula para mantener la estructura y que no haya dehiscencia, que no se aflojen los nudos. Y aquí vemos el resultado post. El paciente tiene el principal objetivo, que es el ascenso de la mejilla, disminución del electropión y mejoría de la simetría facial. Uno de los problemas que nos enfrentamos con frecuencia es la reinervación aberrante que se produce en la parálisis de Bell, donde con frecuencia vemos hipertonía y vemos sinquinesias. Las estrategias para tratar esta reinervación aberrante son las neurotomías, el uso de la toxina botulínica o las transferencias nerviosas selectivas. Vemos a esta paciente con una reinervación aberrante, donde hay una hipertonía del orbicularis oculi, falta de fuerza, una paresia de los cigomáticos. Vemos también una hiperdinamia del platismo. Hicimos entonces neurotomías del lado sano para disminuir la fuerza del lado sano, injerto de cruzado del nervio facial para reforzar la contracción de los cigomáticos del lado enfermo. Aquí vemos cómo estamos haciendo la conexión con las ramas cigomáticas del lado donante del lado sano. Vemos la imagen. Aquí la reconexión al lado débil y una neurotomía adicional a la rama del orbicularis oculi, que en esta paciente tenía 3 pequeñas ramas, para disminuir la fuerza del orbicularis oculi. Aquí vemos el resultado, el pre, el post, y la simetría que logramos. Y vemos en el video, luego de la neurotomía, cómo se amplía el tamaño de la hendidura palpebral y por medio del injerto cruzado reforzamos la musculatura débil del lado enfermo y se le quita fuerza al lado sano. Vemos el preoperatorio y aquí vemos el postoperatorio del paciente hablando. Hemos disminuido ya la hipertonía, en algo se ha mejorado también la sinquinesia. En conclusiones, la parálisis facial es una patología que produce alta discapacidad en el paciente. Las estrategias deben planearse según el periodo de inervación y la edad del paciente. Tenemos entonces unas estrategias claras para menos de 6 meses, otras para 12 meses, otra cuando el paciente lleva 18 y otras cuando el paciente lleva 24 meses, como lo hemos demostrado en la conferencia. La reconstrucción nerviosa inmediata es la mejor opción, mediante neurografias, injertos y neurotizaciones, pero cuando no es posible trabajar a la reconstrucción nerviosa, debemos disponer de las transferencias musculares regionales o libres y finalmente también la utilización de las técnicas estáticas que son complementarias. Muchas gracias.
Great, thank you. That was outstanding. Really appreciate all those wonderful photos and videos so that we can really judge the results. We'll wait to see if we have any questions coming from the group. Remember, you can use the Q&A function to submit a question. I have a question though for you, Raul. When you first started doing this work, you've presented in everything from Mobius syndrome all the way to tumors and all kinds of etiologies of facial nerve. Which were the cases that you underestimated how difficult they were going to be to manage? So in other words, what are the most challenging cases now that you've had all this experience, the ones we should worry about the most?
Bueno, los casos, cada paciente tiene una gran complejidad. Los pacientes ancianos y algunos de ellos que han sido irradiados no son casos porque tienen los dos factores, tanto la irrigación de los tejidos como la regeneración nerviosa más lenta, quizás son los más retadores. En el caso del Medius, pues son pacientes, son niños con gran capacidad de regeneración, aunque técnicamente pues se debe tener el dominio de la técnica para el autotrasplante microvascular, pero tiene la facilidad de ser un niño, de tener la regeneración nerviosa muy rápida y de tener también plasticidad cerebral. Recordemos que la proximidad de la corteza motora del nervio facial y el nervio masseterino están muy próximas y por lo tanto esa vecindad de las cortezas cerebrales favorecen la neuroplasticidad y que estos pacientes niños aprendan a manejar sus nuevas conexiones.
Yeah, I definitely have lost a lot of my neuroplasticity over the years.
Ah, tengo una pregunta. Muchísimas gracias por venir y hablar con nosotros. Pero tengo una pregunta sobre lo de el paciente que tenía lo de neurofibromatosis. Cuando tenía problemas con ese nervio, con el injerto, ¿ha usado las cosas como Axygen, otras cosas que son como de allografts, otras cosas así o no?
Bien, en la reconstrucción del nervio facial necesitamos, por ejemplo, en los crossface injertos muy largos, 15, 20 centímetros, y el halo injerto o el injerto sintético no, de esa longitud no existe. Prefiero siempre el nervio sural, que lo puedo subdividir en 5 o 6 ramas y después hacer múltiples anastomosis. No fue el caso de hoy porque estoy hablando de la tardía, pero es una gran ventaja del nervio sural. El caso concreto de la neurofibromatosis, todos los nervios estaban enfermos. Tanto el donante, el muñón proximal acá, tenía neurofibromas. Fui al pie, tomé ese nervio sural del pie y vieron la foto. Parecía un rosario lleno de tumores. Yo hice de todas maneras la anastomosis y esperé 3, 6 meses, no funcionó. No fue un fracaso. Entonces tuve por eso que abandonar las técnicas de reconstrucción nerviosa. No era posible. Ni siquiera pensar intentar en un crossface porque también estaría el donante enfermo. Entonces por eso fuimos a hacer una transferencia muscular ortodrómica. No era posible la cirugía. Es una experiencia interesante que me sorprendió el precio.
Muchas gracias.
Yeah, very interesting case. We'll do one more question and then we'll move on. And that question was coming from the group. Do you do dynamic muscle transfers like gracilis flaps in cases that you expect to need post-operative radiation? So in oncologic cases where radiation is going to be delivered after you do the gracilis, would you do it at that time or would you wait and have the radiation performed and then go back and do the facial nerve reanimation?
En los casos oncológicos hay de dos tipos, los que son neuroquirúrgicos. Entonces, no disponemos de un cabo proximal. Entonces, los meningiomas, neurilemomas del octavo, del séptimo par, esos pacientes generalmente llegan a mi consulta 3, 6 meses tarde, porque el neurocirujano generalmente los envía a fisioterapia y él espera, y ellos siempre dicen, no, yo no dañé el nervio, yo dejé el nervio intacto, ahí quedó muy bien, pero en la práctica yo espero 6 meses y si no hay respuesta, inmediatamente ya le indico al paciente cirugía reconstructiva. Entonces, estos casos, operándolo al 6º mes, generalmente puedo hacer una reconstrucción de tipo nerviosa. En los casos oncológicos de la cara, fundamentalmente son tumores de la parótida. Y en estos pacientes siempre estamos trabajando simultáneamente. El cirujano oncólogo está retirando el tumor de la parótida y yo estoy pendiente. Si hubo resección del nervio facial, inmediatamente entro a reconstruir con injerto nervioso. Entonces, en estos casos, generalmente hemos podido hacer injertos nerviosos tempranos con excelentes resultados porque la cirugía es el mismo inmediatamente. Los casos de gracilis los he estado haciendo entonces en pacientes que han estado mal orientados, pacientes neuroquirúrgicos que se han esperado demasiado tiempo y han pasado los 2 años. Pero entre más hemos ido conformando equipos interdisciplinarios con el neurocirujano y con el cirujano de cabeza y cuello, estamos reconstruyendo los pacientes de forma temprana y generalmente por injertos nerviosos o por transferencia nerviosa podemos lograr la reconstrucción. En el caso de los pacientes con síndrome Mebio, sí es mandatorio, obligatorio hacer la transferencia y el músculo, el trasplante de músculo grácil.
Yeah, it highlights the importance of working together on teams. So really appreciate that. Well, thank you so much. That was outstanding and beautiful, beautiful slides and results. So I think we'll move on, and we're fortunate to have Professor Juan Larranaga, who's the head of maxillofacial surgery at the Hospital Italiano in Buenos Aires, Argentina. And he's going to speak to us a little bit about mandibular reconstruction and dental rehabilitation. So please share your screen and your thoughts. Appreciate you being here.
Thank you. Let me see. This goes. Go there. Can you see it there? It's okay.
Great. Yep, looks great.
Perfect. Okay, let's go back. Okay. Well, go back. Okay. Okay, thank you very much. It's a pleasure to be here with you tonight. I was giving a topic that's a little big for that. It was maxillary and mandibular osseous reconstruction and dental rehabilitation. So I will try to talk about everything. And I know there's a lot of levels of people in this talk, in this meeting. So I will try to talk a little bit about the complex things and the simple things. But I'll start from the beginning. So what are the learning objectives in this talk? We are going to define the main aesthetical and functional goals of maxillary and mandibular reconstruction. We're going to analyze the indications of available resources in alloplastic, non-vascularized bone, and vascular bone flaps. We're going to analyze the medical comorbidities and adjuvant therapies that influence the reconstructive choice. Sorry, this doesn't go there. Okay. Mandibular, we have a different kind of cases. The most common things that we're going to talk about are tumors, trauma, and osteonecrosis. Usually these kind of patients are associated with mucosal defects or other defects. They can have a piece of tongue and maybe an orbit on whatever, compromised also in the resection. The patient may have other medical comorbidities or have to do other adjuvant therapies like for example, radiotherapy or chemotherapy or whatever. And dental rehabilitation is the final goal, but it's not always achievable. Not all patients get rehabilitated in any center. And what are the primary goals we look for is to restore osseous continuity, to restore facial projection, to protect the airway, to separate the compartments, to separate the mouth from the nose, to separate the mouth from the neck, to prevent soft tissue retraction, mandible lateralization, and TMJ dysfunction and pain. And the secondary goal and the end goal of every reconstruction of the mandible of the maxilla is the dental rehabilitation. And in the whole thing, we look for aesthetic satisfaction and at the end, in improvement in quality of life. So how did we start? Around World War I, we had delayed reconstruction with grafts, with bone grafts, and they used to do good, some of them good, some of them bad. They had around a 75 success rate. I don't think that is really true. They're probably much lower, but that is what is published. And usually they were delayed reconstructions. In World War II, we get better with delayed reconstructions with grafts and alloplast. We have antibiotics that improved a little bit the success rate. They probably covered the grafts a little better. And then in the 60s came the microvascular flaps and the composite transfers, and this changed completely the results of maxillary and mandibular reconstruction. And now we have that immediate reconstruction is available, reliable, and it's obviously the gold standard, and delayed reconstruction is, with time, is less recommended. And I'm going to talk a little bit about that because reconstructing afterwards, it's a little bit more complicated, and you get patients like this that have a delayed reconstruction. You have to do that, and the results are not optimal. So how do we evaluate the patient with a bony defect of the mandible or the maxilla? We have to think about the amount of soft tissue and the amount the bone tissue lost. We have to, in the soft tissue, we have to take into account the quantity and the quality of the soft tissues we have. If we had prior interventions, if we had radiotherapy, if we have vessels available in the neck, what are the chances of postoperative salivary contamination? Because if we have that, maybe a bone graft is not the best choice. And obviously, the characteristics and comorbidity of the patient. So what are the reconstructive options we have in this kind of patients? We have an obturator prosthesis for the maxilla, only in the maxilla. We have temporary or definitive alloplastic bridging, only in the mandible. We have non-vascular bone grafts, regional flaps, and free bone flaps. Obturators, well, it's an easy option. I still use it. I still use it sometimes. I have an 82-year-old patient. I had to do a maxillectomy, and the patient wants to go home, read a book to their grandchildren, and don't go anywhere else. Well, this can be a good choice, and for many patients, you can do that. If you want to talk about reconstruction only with plates, well, it's not the best thing to do. You have a lot of complications, especially if you treat the symphysis of the mandible. But if you have an old patient with a poor oncologic prognosis, and maybe you want to do a transitory reconstruction because of some health status or condition, you can choose to do a reconstruction with only a plate. Like I say, the best thing is to do it on the lateral side of the mandible, not on the symphysis. The symphysis, you will probably have a failure. You need absolute stability. You need adequate soft tissue coverage of that plate. Sometimes you need to put a big flap in there. You can do a pec flap, or you can do any kind of microvascular flap, an ALT, a radial forearm, or whatever. But you have to have really good coverage. And like I said, it's preferable in a lateral defect. This is a paper by Fu Chen Wei, and a pretty old paper from 2003, where he did an 80 patients with titanium plate plus a microvascular flap. They had 70% complications, 46% of exposure. I worked for a long time I worked with Fu Chen Wei. I was there and I don't know if at that time, but a couple of years later, probably at 2007. And actually, if you are there, probably the best thing to do is to do a free flap. Okay. So there's a patient like that with probably a bad prognosis or something, or a very old patient. And we did a plate and a radial forearm. Like I said, if it's a small defect, it's in the side of the mandible, you probably do well, but it's not the best choice. Reconstruction with bone grafts. Well, bone grafts for me and for many people still play a role in mandibular reconstruction. Their use should be discouraged in immediate composite reconstructions. If you have to take a piece of mucosa, a piece of the floor of the mouth or whatever, I don't believe it's the best choice. If you have loss of soft tissue and you have to take soft tissue from somewhere else, probably a bone graft will not be the best choice. In irradiated patients, also not a good choice. If you need postoperative radiotherapy, or in maxillary reconstructions. In the maxilla, if you put bone grafts, they're usually in contact with the sinuses, and you usually have problems. So, but if you talk about mandibular reconstruction with bone grafts, I like to use it if there is no contamination. There is a paper that says that stated that defects bigger than 5 centimeters should be done with a microvascular bone flap, and smaller than 5 centimeters with you can do a bone graft. This, I think it's a good rule, but I think the most important thing is contamination. So if you have a patient that you can operate from the outside and it's gonna not get contamination with saliva or whatever, you can do bigger defects than 5 centimeters, and probably you have a good result. You can do corticocancellous in block grafts. You can do particulate grafts. I like particulate grafts better. If you're going to do in block, it's important to have compression between the stumps, fixation with locking screws, and stable graft fixation. It's mandatory. When it's not advised, when there is not enough soft tissue to cover it, when there is oral contamination, and where you are planning for immediate placement of dental implants. You cannot do that in bone grafts. But dental implants in the delayed setting is highly successful in this kind of patients. This is a patient, like I said, a small defect in the angle of the mandible. It's not going to be in contact with the mouth, and we use a corticocancellous graft, and it did pretty well with time, and then we could rehabilitate this patient. But like I said, if you're going to do it in the maxilla, it's not usually a great choice. This patient had a bomb explode in his face, but he had a whole bunch of little pieces of bone there, and I said, okay, we can give it a chance. We can do a bone graft there and see how it does, and you respect the pillars and whatever, and maybe graft a little bit and here and there, and we did a fan flap to cover soft tissue. Not a good choice, like I said, in the maxilla. I don't like it. We didn't ended up doing a fibula flap, and the patient did well afterwards. So regional bone flaps. For me, it's not a choice now, but some people do it. I've done all these flaps. The pectoralis major with rib. I've done the trapezius flap with scapula, and I've done the scapular artery perforator flap with the medial edge of the scapula. What indications could I find? Major defects in a patient with a vessel-depleted neck. I had patients who have stents in the neck and whatever, and you cannot do it any other way. Maybe that's an indication in the rescue setting, but only for mandibular reconstruction. This is a trapezius flap, a lateral trapezius flap, taking a patient who had several flaps done before, had no vessels in the neck, had only one carotid artery with a stent in it. So, well, I think that is the kind of patient you should use it, but not the gold standard for a long time. So, free flaps. Free flaps are the gold standard now, and that's what I mostly do. Maintenance, they have maintenance of endoosteal and periosteal circulation. The bone is stable to tolerate functional load sooner. You have primary bone healing, and it can be combined with soft tissue. We all know that all kinds of flap we have, like fibula, iliac crest, scapula, radius, or whatever. We can do skin paddles. We can take muscle with that. We have no rotational limitations, and we can do immediate implant placement. So for us, it's the gold standard. The fibula in this paper from Cordeiro and Hidalgo is the most used flap. You know why? It has all A's there and a B and a C, but it has a long pedicle. You can do it at the same time as the resection. It has long bone, good bone for implant and whatever. So the fibula, you can have up to 25 centimeters of bone available. You have to preserve the 8 centimeters distal and 6 centimeters for the pedicle. It's usually have a skin paddle that is usually thin, but it's fixed, and sometimes it's difficult to move if you don't dissect the perforator itself. You can do multiple osteotomies and still have segmental irrigation. You can do immediate implants, and you can harvest the flap at the same time of the resection, and you usually have very low donor site morbidity. With virtual planning and models and navigation now, you can have much faster, better results and whatever. And well, I'll show you a case of this. This is a fibrous dysplasia with an osteosarcoma. You cannot get this reconstructed with any other flap. Yeah? This is a huge, long segment, a huge, long defect. We have probably done 1, 2, 3, 4, 5, 6 segments of fibula to go from one mandibular angle to the condyle on the other side. And it's usually a very straightforward surgery. The result was up with dental implants, and the fibula is great for this kind of long result defects. The fibula can be also used for the maxilla. You can do it in several segments. You can plan it preoperatively. That gives you a lot of predictability and you can save a lot of time. Here we navigated the osteotomies in the face for a squamous cell carcinoma of the maxilla. We navigate also the osteotomies in the fibula, so we can have different kinds of options. And there we go with the defect. I try not to use the result. I try not to use a lot of skin paddles because of the difficulties afterwards to put implants. So I usually use the flexor hallucis longus, and I leave it in there in the mouth, and it reepithelializes really well. So, well, what other choices do we have? We have the iliac crest. The iliac crest is great, but it has two problems. It's a short pedicle, and the skin paddle is no good, and it has a lot of donor side morbidity. But still, you have a very, very good height of bone in atrophic mandibles. That is pretty important. The bone for implantation, I don't like it a lot. In the literature says it's really good, but I don't like it. I don't like it a lot. And what I like the most about the iliac crest is the minor oblique. Because when I do a maxillary reconstruction, I have to replace the whole palate, and I have to use with a fibula, I have to use a skin paddle that is big, it's fat, it's complicated. I love the minor oblique. It replaces the whole palate ideally, and it takes the shape of the palate. So that's why why I use it the most. This is a defect, a maxillectomy. I did an iliac crest here. You can see there the nerve and the flap. And sometimes when you use one segment only of fibula, the segment of iliac crest, it's a little bit far behind. So you have to pull it forward or take it a little bit down. So we use a distractor there, and so we can get a better position for implantation. And this is the post-operative result of the patient with the minor oblique there inside the palate. The other flap, the scapula flap, the problem is that you don't have a simultaneous dissection. You have to turn the patient around. I don't like that. The bone, if the patient's not a big patient, that is it's a thin and small patient, there is less implantation possibilities because the bone is thinner. Shorter bone replacements because you cannot do the whole amount of segments you can do with the fibula. It has low donor side morbidity, and the best thing about this flap is that if you have a huge defect and you have two paddles, you need two paddles, one for the inside, one for the outside, or you need to fill some big defect of volume, you can use the latissimus dorsi, or you can do both two skin paddles at the same time. You can do chimeric flaps. This is a patient with an osteoarterial necrosis, with a bone exposed. And one good thing about the scapula is that if you have a patient that doesn't have good vessels in the legs, doesn't have good vessels in the legs, you cannot find other vessels. They have a bad iliac crest or whatever. Usually the scapular vessels are good, so you can use those. And this is the case in this patient. So we replace the mandible there with one segment or two of scapula and a big skin paddle. Well, and I had to talk also about dental rehabilitation. You could talk 2 hours about dental rehabilitation, but it's the gold standard, but it's not always achievable. It's high cost. The patients usually have to pay it by themselves. A lot of patients have bad prognosis and never get the rehabilitation. They do radiotherapy, whatever, and they never get their teeth, and others have complications. But well, what are the biggest challenges we face when rehabilitating these kind of patients with free flaps? We have an altered anatomy and an altered occlusion. We have a huge problem usually with the lack of vestibular depth. I tried to fix that with many kinds of things. I've done skin grafts, I've done free flaps for that, and you never get it completely right, and the lip is usually a little bit high or a little bit low. Bone height for implantation, sometimes the bone, if you do a single fibula, it's very low and you have to push it up. You can do vertical distraction for that, or you can do a double barrel fibula, but you have to be very careful with the double fibula to do it just in the front part of the mandible, and don't go back, because if you go very high in the back, sometimes they can't close their mouth. The soft tissue bulk, you need a lot of revisions. Like I said, if you are going to put implants through a skin paddle, you have to thin the skin paddle, always thinking, I'm going to kill it, I'm going to kill it. No? And well, it's a problem. You have radiation-related complications when you put implants. You have to think, an important thing is to think about primary or secondary implant placement. If you're going to do radiotherapy, usually the implant placement, or what the publications say, is that put it in there before and do the radiotherapy after you had the osseous and when the implant sets in. Peri-implantitis or granulation tissue formation around the implant is extremely common, and you have to get the patient to come and take it out all the time. And dental hygiene, when you have a prosthesis that is fixed, it's also a problem, and you have to clean it up usually often. Like I said, one of the problems is the loss of vestibular sulcus. Here is an iliac crest for the maxilla, and these patients usually get that. She's smiling there, but if she stops smiling, she probably still look like she's smiling, because the lip never goes to exactly the same position anymore. Vertical distraction of the fibula, it's an option. Try to do it from the outside, not do it through the inside. I had complications if you do it through the inside. Sometimes it gets contaminated and you have problems. This is a patient, we did that. Like I said, soft tissue bulk, it's a problem. You have to thin these flaps to put implants through them. But well, the success rate is really high in non-vascularized grafts and also in free flaps. So it's a gold standard. Try to do it if you can. And prosthodontic options, you have the fixed implant supported prosthesis. You can use hybrid prosthesis, fixed and removable. That is better for cleaning over dentures. Zygomatic implants for maxillary defects, and superosteal implants that I'm thinking about using now more and more. I don't know if they're gonna do well, but if you have a defect of the maxilla and you can put an ALT there in a patient that's 80 years old, and you can have implants done and rehabilitate that patient in the same week, and they're not gonna chew with that maxilla for the whole life, I think that could be a good option in the future. Take-home messages. There's many options for reconstruction, but immediate reconstruction with free flaps is now the gold standard. Dental rehabilitation is the final goal, but it's not always achievable. Even if dental implants are placement is 90% successful. A multidisciplinary approach is mandatory, and technology and new implants improve results and save time. Thank you very much.
Oh, well, thank you so much, Juan. Great to see you, and that was excellent. And you actually did a great job covering a huge topic in a pretty short period of time. I'm going to ask you one question, and then I think we got to move on. And that question is delayed reconstruction for osteosarcoma. Currently, do you do a quick delay and wait for margins on your osteosarcomas, or do you just do virtual planning and plan a bigger margin? Because right now I tend to just plan a bigger margin. I do immediate, which kind of goes against the traditional dogma. And I just wondered what you did.
I do exactly the same. I plan for a huge margin.
Yeah. Okay.
I prefer to have one segment more of fibula and don't have a positive margin.
Yeah. Yeah. Agreed. Well, that was outstanding. Thank you so much. So we'll finish off with our final presentation, and we have Professor Jose Carlos Marquita Faria, a plastic surgeon from University of Sao Paulo in Brazil, and he's going to talk to us how to optimize outcomes in pharyngeal reconstruction. And I can't wait for this talk, because this is always a challenge for all of us to get the pharynx reconstructed without having major disasters. So hopefully he can give us some tips, and I really appreciate his time. Juan, you may have to stop your screen share so that Jose can share.
Presentation. Let me.
Yep.
I stopped it. Eh?
Yeah, it's good. So Jose, try again your screen share and I'll tell you if it comes up.
Okay.
Yep,
Is it good?
it's good.
Okay. Okay, good evening, everyone. I decided to speak in English because I found it was very hard to follow the images and slides and read the small subtitles. So, and I put a lot of images in this presentation, so I hope they will speak for themselves and you won't notice how bad my English is. So thanks for this opportunity. Thanks, Dr. Brett, the American Head and Neck Society. I also would like to thank Dr. Kowalski, the most known head and neck surgeon here in Brazil, who made this participation possible. I'm a plastic surgeon. I've been doing head and neck reconstruction for the last 30 years. So when I talk about head and neck reconstruction, one thing that calls my attention is that the functional impairment is not proportional to the defect size, because there are very important areas and they share very small anatomical structures. Even small defects can lead us to very, very bad functional problems. A natural flap inside the mouth is the tongue, and that can be used to close lots of defects inside of the mouth, but you make it more difficult for the patient to swallow, to speak. So even in small defects, we can think about something else. All reconstructive procedures, they share one goal, just restore the anatomy. And that's what we have in mind before we start any reconstruction. So we gotta make that look as close as possible to the patient, what he had before the defect was performed. Unfortunately, you're not born with spare parts or don't have twin brothers where you can harvest these tissues. And we got to think about something in a patient that we can use to work as similar as possible what the patient just lost. And the way we transfer these tissues is by conventional flaps or free flaps through vascular microanastomosis. There's an example of like conventional reconstructive procedures. This patient came to me like this. They tried the pectoralis flap, a deltoid pectoralis flap. None of them work. And then a free flap was the only option. Well, talking about conventional flaps, the problem that I see is that it's not uncommon to have a partial loss of these flaps. And if you're reconstructing something inside the mouth, these little losses may take us generate big problems, the fistulas. So we don't see that very often in the free flaps. Fistulas for me, and I'm not ashamed of affirm that, unless the patient is malnourished, are almost always a consequence of technical problems. So my reference is always the surgery that I did yesterday, because the surgery I'm going to do tomorrow is going to be better than the surgery I just done yesterday. So if compared the rate of complications, the complications rate of free flaps, if the flap survives and the chance of it not survive is very small, and if it fails, we got to decide, I can't wait. I got to decide and do a second procedure immediately. When we use local flaps, sometimes we have like to delay, wait until we see how big the loss is, and the patient like would get into in a way that it's just is not. We don't have a definite solution. And free flaps, you always got to think fast, and the surgery is predictable and very resolutive. For us, free flaps are always a plan A for oral cavity or pharyngeal reconstruction, what I'm going to talk about to you. Conventional flaps are important, but for me, I see them as always plan B. Even in small defects, this patient has an ulcer necrosis induced by zoledronic acid. It's a very small defect. And most of the surgeons say, let's close, and the mucosa will be able to close primarily. But the problem that I wouldn't fill the dead space. I won't treat, I would cover, I would close the hole, but I won't solve the problem. So even for the small case, I do a very small flap. There are no other incisions in the mouth. I control the post-op. So the post-op, the trans-op, and the post-op are very predictable. And the fact that they have a vascularized tissue in contact with the bone, we solve the problem. This is a very resolutive procedure that we do. And the donor site was closed primarily. So this is patients say like, there's no need for ICU, post-op, and the patients are no feeding tube and can be discharged from the hospital the next day or 2 days after the procedure. So when we do a reconstruction, we're going to think about flap selection. And the ideal situation, it would be the flap that would provide the best donor defect benefit with the lowest donor site morbidity. But this is compared, like skin graft is a much more simple procedure than a free flap. But look at the donor site morbidity. It's a lot worse for the skin graft, considered as more not complex procedure. And it's free flaps we control this donor site morbidity and make it both distant donor recipient site and donor site. I think is something very important for head and neck reconstruction. I'm not still talking about flap selection. We are very different. We look different. We have different proportions. What does that mean? That there's no cake recipe. I can't say that I gotta use the same procedure always for the same problem. So the decisions are made alone. So I believe there are many ways to get us to the same destination. There's not just one recipe. And when the patients look for me, and of course they want to know what I'm going to do, I just tell them, I don't know what I'm going to do, but I assure you I'm going to make the best decisions along the procedure. As a matter of fact, when we started the surgery, we started just a chain of decisions. Because we got to, during the procedure, we collect information that can lead us, like the flap, where the periphery is, where how the clinical, the patients, how his clinical conditions, bleeding, what the head and neck surgeon had done before I start my part. So every stitch is also a decision. If it doesn't look good, do it again. And never, in my practice, finish surgery, think that you might have done it better. So I don't want to show you or tell you what I do and how I do it. I would like, to tell you how I think during the surgery and when I face a problem. My microsurgical team is me and my nurse. I have 3 in my life, and I have many, many, many physician assistants. Why? In order to control the results, I like to do almost everything. And the only thing that I don't do, and I gotta confess you, is close the donor site. This patient, I use a lateral arm flap. I close almost everything, even the part that has most tension close to the elbow joint. And the part that I didn't suture, let my assistant to do it. And 2 weeks later, the patient came to me with an open wound. So it's not what you do, because we have a tendency to find numbers, to translate everything that you do in numbers, to apply the statistics. This is not what matters. It's because most of the things we cannot measure. So more important than what we do, it's how we do it. This patient looked for me to do a hard palate reconstruction, very simple reconstruction. And she was not happy with how much I charged her. So she looked for another surgeon and she disappeared. 2 years later, she came back to me and she had this big incision here in the neck. This is the donor site appearance, a radial forearm flap. And the patient, the surgeon, lost the flap. She still had a hole. And then she decided to do with me. the same procedure, same problem, the procedure that receives the same name can be performed under so many different ways. And we gotta find the best way. Here, the scar under the jaw, a smaller here with a total skin graft to the donor side. Patient need like a tattoo. So this is maybe the difference is small, but it's for me, it looks like I've done better. Doing microvascular anastomosis, this is something that we already overcome. We know that we have, the success rate reaches, like Dr. Juan said, 96, 97, 98%. This is not a problem anymore. Even when we talk about a patient who underwent a bilateral radical neck dissection, and the head and neck surgeons left me no branches to use as a recipient vessels. No problem. I use a vein graft, a venous, a loop here between the carotid artery and the internal jugular. And this is my pedicle. No problem. This is something that is not a problem anymore. However, when you do with the surgery, I do my part, everything, but I'm not an oncologist, I'm not a head and neck surgeon. And sometimes this patient, I did a free flap, I lost the flap, not because I had a venous thrombosis, but because the patient had the internal jugular thrombosis. So this, the team talking, the same language is very important. The head and neck surgeons and the reconstructive surgeons. Talking about pharyngeal reconstructions, we're not reconstructing something static, something that doesn't move. This moves. In order to breathe, to speak, to swallow, we're dealing with the structures that have movements, and these got to be addressed when we think about reconstructions. However, it's unless we're doing like facial palsy, like Dr. Juan showed us, it's very hard to restore the movement. But we gotta keep the maximum mobility of the surrounding tissues. This is very important. And I'm gonna show you why it's important. Sometimes, most of the times I cannot reconstruct the motion unless I'm doing like a jejunum for esophagus reconstruction. But I got other procedures that can compensate the lack of motion. Like I can increase the size, I can change the position of the tissues. This is very important in the rational. I'm going to talk a little bit about tongue reconstruction, partial glossectomy. I can tell you, patients that lose half, maybe a little bit over half of their tongue, they can speak normally with the construction, not because we construct something that moves, but that we can keep the maximum movement of what's left. See, this patient went a partial glossectomy, and I use the lateral arm flap, and I can adjust the flap. If it's a more superficial defect, I can harvest more the skin of the forearm. If I need more volume, I get the tissue more in the arm. So I can adjust that in order to get the best anatomical reconstruction. Unfortunately, for a total tongue reconstruction, this is I tried like even a gracilis, high nervated gracilis, but I gotta tell you that's what matters is like providing volume and a nice anatomical disposition of the tissue that can make the food glides inside the throat and the patient is able to eat. It can speak, like, of course, is something very challenging for the reconstruction. For pilot reconstructions, hard pilot reconstructions, using an prosthesis, the patient got to remove that to clean inside the mouth. This patient won't be able to turn the page. So I think this is the best functional and aesthetic reconstruction. If he needs bone, I can add bone. If he needs just skin, I put skin, but you can get this patient completely to restore completely the function. More challenges is when this defect reaches the soft palate, because something that moves, and the patients, in order to eat well without food coming off his nose or speak right, I can do this. I can reconstruct the movement of the soft palate, but I can adjust that. This is a very long flap. If you can see here, I harvest the flap almost half on a middle way here to the wrist in the forearm, and the flap here half of the arm. So this is a very long flap. much longer than the defect that was shown to me. And what I do, I insert this, the insertion of the flap goes lower and longer to the posterior wall of the pharynx. And that's how I do it. And I'm gonna show you this patient.
Aí, vamos lá. 1, 2, 3, 4, 5,
7 days,
6,
pulls out.
7, 8, 9, 10.
Patient
Isso aí.
eating, I can understand everything that she says, in Portuguese, of course, but she's eating, and it's just before we remove the feeding tube. A week later, after she underwent a hard and soft palate reconstruction. Esophagus reconstruction, something that's a non-circumferential defect. This is an adjustment, since you don't have the peristalsis that makes direct the food downward. So I just make a wider tube. So the patient that I showed in the beginning, radial forearm flap, frozen neck, do require radiotherapy. No problem, they use the internal mammary vessels. And this is the patient without the feeding tube, gain a little bit of weight. This is the only part that I may consider a local regional flap, a pectoralis flap, who works well, like a patient that didn't have a very good conditions. This is a total laryngectomy. Inside the mouth, flap, suture, and also had a little bit more to reconstruct the tongue. So for circumferential defects of the esophagus, for me, this is the best option, this jejunum. It provides gliding in a tube, and also can, in the patients, or these salvage procedures, you can use part of the bowel and open it, use as a recipient bed for a skin graft. So it just, because when it starts surgery, the patient gets swollen, you won't be able to close primarily. You don't want your free flap to be squeezed like in a small pocket because you try to suture the skin primarily. No problem. That's just one procedure. You solve 2 problems. It is a skin graft and the patient eating without a feeding tube. And here, like I'm almost done with my presentations, talking a little bit about larynx reconstruction. It's a very challenging because we need to breathe to survive, but also the patient, he wants to swallow, to eat, and talk. And sometimes for these defects, to have both of them is not easy. I'm going to show you 2 cases. One of a subglottic laryngectomy. This is a patient who had a chondrosarcoma of the thyroid cartilage. He underwent this laryngectomy. And because it's like a tumor with a slow growing, we had the possibility to prefabricate a flap. So I inserted like a metal net under the radial forearm flap. And I waited until this metal was integrated. This is the flap suture. How I do suture, PDS stitches. And this is the patient. He sent me on his birthday. It's not a normal voice.
Tá bom. Conta até 10. 2, 3, 4, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. Isso aí. Consegue comer tudo, Roberto? Consigo. Sem sonda, sem gasgar e sem tossir. Sem nada, perfeito. Roberto Mariani.
And another, to finish this, as translate laryngectomy, something kind of very challenging reconstruction. especially in this patient. This patient is a very famous rock singer here in Brazil. And he you can see the retinoid, the symmetry, left side swollen. He had a tumor. Underwent biopsy and showed the squamous cell carcinoma. So he went a lot. This transglottic larynx reconstruction. This is the epiglottis. This is the glottis. This is the pharynx. I plan on doing a lateral flap. This part here would stay inside the throat, the larynx. And I also harvest this little skin item that would stay outside so it would monitor the circulatory viability of the flap. This is the hyoid bone to provide the structure where the flap would be supported by. This is the patient. The skin pedal was removed later on, his evolution. And this is this patient. You can see that the left side was not moving because this is the flap on the right, which means the left side of the patient. You can see the right retinoid moving. The patient asked me, because he play guitar, asked me to have the flap on the left side.
Cabeça dinossauro. Rapidinho. Cabeça pé, dinossauro. Fica cansado. Pois é. Realmente, eu tô muito feliz.
So I'd like to finish this presentation because we are very lucky as reconstructive surgeons because we see what we do. And if what we see is not good, we have the opportunity to fix it and do it better. So it's quite very simple to reconstruct because the goal is just one, to get closer, to have similar structure position, what we had before the patient underwent like this tumor ablation or trauma or anything else. We can almost always improve the life quality. And I also think that we may be able to increase survival rates because Dr. Kowalski, he says when I'm in the operating room, he already increased the margins by 1 or 2 centimeters. So he's more radical. So it's this, I think this is something, I love what I do. And I love not knowing what I'm going to do exactly when I start surgery. Thank you.
Well, Jose, that was excellent. Thank you so much. Very fun talk and thoughtful about how we think about improving, not just showing some technical slides about how you solve problems, but just how you're thinking about the problem. So I really appreciate your time. We didn't have any questions. Alex, did you have any questions for the panelists?
No, I think everything was wonderful, and I loved getting to see kind of techniques and the approaches that everyone has, because it is every day is a little bit of an adventure, and getting to reconstruct people and seeing them on the other side, smiling at you when they have their new teeth or talking to you when they have their voice back. So always wonderful to hear perspectives from all over, and really glad that everyone could join.
Yeah, that was outstanding. And I may wake up in a cold sweat with that thrombosed jugular vein picture in my brain. that one won't leave me very soon. I've been there before. So
No kidding. No kidding.
a great job, everyone. I really appreciate your time. I know it's a night and for many of us. So thanks. And to all the participants who joined, really appreciate you joining in, and hope you join other AHNS webinars. We have a series of them, so look out for those. And I think you can pick up a lot of tricks and tips from the masters when you log in. So thanks so much. And I will let everyone go. Have a great night, everybody.